Hello and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session, Medicare Regulatory Update 2025 IPPS Final Rule. We're pleased that you've joined us today, and now I'm going to play our housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, and with that, now I'd like to turn the floor over to Eric Lucas, Managing Director here at Moss Adams, to get the presentation started. Eric?
Hi, thanks for joining us today. We're going over the 2025 IPS regulations for inpatient reimbursement. Joining me today, I have Georgia, who's going to be talking a little bit later about the team model that has come out, and Jonathan, who will going over the Medicare Dish Uncompensated Care. In the meantime, I'll be going over the payment rates, some wage index changes that have occurred, and some other factors that are impacting IPPS. I'll give you my general consensus is I tend to think that this was a pretty significant change for an IPPS or for a payment year. However, not everybody's going to feel it equally as we kind of talk through this. So it'll be, some hospitals might consider this not really a big change from last year, and some are going to consider it a groundbreaking change as they hear more about some of the changes that have occurred. So let's go ahead and get started. So let's start with payment rates. Overall, CMS is finalizing a overall payment rate of 2.9% increase over prior year, which we'll talk about. That's for anybody that's any hospital that has become a meaningful user or is reporting the quality measures. That's an increase 3.4% with a 0.5% productivity cut. CMS is estimating that to be an overall $2.9 billion of additional reimbursement over 2024. For comparison purposes, last year it was 3.1%, so it is coming in lower. I'd point out, though, that there was quite a lot of advocacy effort to try to get a larger increase in this year, specifically because of all the inflationary concerns across the industry. AHA was one of those. A few other organizations also commented to the need to have a higher than proposed rate increase, yet it did not happen. And one of the final ones was MedBack, who came out in suggested that given where inflation has ended up, a 1.5% increase over the proposed was more in line with what hospitals should be receiving, and CMS has chosen not to move forward with any additional change. So we're looking at a pretty average payment increase from what we typically see from CMS in a year where we're seeing quite a lot of inflationary growth in labor and supply costs across the industry. So to look at how this all lays out, the market basket, as I said, is 3.4% with an overall 2.9% increase. For those hospitals that continue to not report their data or show that they are meaningful users, there's still a reduction. Surprisingly, there still are a few hospitals that fall into this bucket. And as been the case for a few years now, not doing either one of those is actually resulting in a reduction to the rate. So hospitals could be seeing some downward pressure year over year by not doing one or both of these things. So let's just kind of lay out the complexity of the inpatient factors that go into the rate. Let's start with how we take the operating payment rate and we split that up between a labor and a non-labor share. We do that because the labor share is going to get a geographic adjustment factor called that's called the wage index. We're going to talk about each one of those individually, but let's just start with the fact that we're going to break up a labor versus a non-labor report. The labor percentage is deemed at 67.6% for those with a wage index factor above 1 or above average, and those below a wage index factor of 1 will see the labor percentage of that operating factor at 62%. This has not changed from prior year. They went with the same percentages as they used in the past. And you can see that breakout here. So in comparison to 2004, you can see how the payment rate change on just these particular factors has changed year over year, and how the labor and non-labor is broken out to get to that overall payment rate. To overcomplicate this issue, we're going to be talking about a lot of different programs, not all the ones that are listed here, but in order to make every one of these programs that CMS implements through the fee-for-service model budget neutral, they have to adjust it out of the rate. And so we see quite a lot of adjustments here to get from the actual base rate of $4,782 down to what is ultimately going to be the rate. And so it's important to kind of point out a couple of these we're going to be talking about here. The operating outlier factor, that's standard. You know, the fact that a portion of payments have to come out to pay for outlier payments has been a common theme. And then a ton of wage index programs, particularly the lowest quartile, which we'll be talking about here in a little bit, is also a means of adjusting policy through the payment factor to make it budget neutral. Come on, cursor. There we go. And here is the capital piece, very much similar factors. So let's talk a little bit about outlier that I just brought up because there is some interesting policy here. Number one, CMS has indicated that, again, the outlier went over. And this is surprising. If you had joined us last year, actually probably the last 2 years, I keep saying, oh my gosh, the outlier threshold is moving up pretty rapidly. And in those cases, typically CMS was saying, well, we are changing our approach to make sure that we're not overpaying on outlier. There's no roll forward mechanism here. If they overpay on outlier, they're not taking out the following year and vice versa. And so CMS does its best to estimate where they expect outliers to be and make adjustments accordingly. So they, in their efforts to get to the 5.1% that we talked about earlier that they reduce out of the rate, they make a number of adjustments to properly estimate that given changes that are occurring at the hospitals. And in 2022, they identified that they actually overshot by 6.8%. This year, we're seeing a 8% growth in the threshold. It's a lower than what was proposed, though. Proposed, the threshold was 49,237. So there is some additional effort to get that threshold down, but we're still looking at a fairly large increase to the threshold occurring for the third year in a row. One of the factors, though, that hospitals need to think about here is in the proposal, CMS had identified a change to the outlier reconciliation process. This is something that was introduced back in the early 2000s, and is being adjusted now with the intent to actually get more hospitals into the bucket where they will receive a reconciliation. So they changed the parameters here. So there's outliers over $500,000 and a 20% change to the cost to charge ratio. The hospital will be subject to an outlier reconciliation. And so CMS is expecting a lot of additional hospitals falling into that bucket. They completely acknowledge that could mean additional funds to the hospital if the cost to charge ratio is actually going down. But in most cases, they expect that this is going to be a loss to the hospitals. And they changed the calculations throughout IPPS in determining what the threshold should be, and in some of the other factors that required the outlier calculation. They have changed to include estimates that they expect to get from the outlier reconciliation with these additional hospitals impacted. So let's move to MSDRGs. The DRG weights were recalibrated as they typically are. They're using the 23 MedPARK claims, the 2022 cost reports for these rates. There are 12 new MSDRGs this year, just as proposed, and 5 MSDRGs had expired. Typically, these were those 5 DRGs that expired were just expanded with more content to break them out into the 12 new DRGs. The one thing I would point out, though, is there is quite a lot of changes to the weights. 40 MSDRGs increased by 5 to 10%. The 47 decreased by 5 to 10%. The one that you might want to look at is the 31 MSDRGs that decreased by 10%. That 10% is a cap. No DRG can actually decrease by more than 10%. And anything that's on that list, you can see that some of those are going to decrease year over year because they're so far below what they were in the prior year. So in some cases, we'll see probably 2 to 3 years worth of reductions to those DRGs. You can start to anticipate now, given where the current levels are. Here are the 5 largest increases. We could have done the top 10 or top 20, but these 5 are significantly different from the prior year and probably worthy of taking an additional look. A 65% increase year over year is a dramatic reimbursement increase from the prior year. And DRG 509 arthroscopy is a common DRG, so it's one that we can anticipate that it's going to have impacted several hospitals. They're using Grouper software version 42 as proposed. The Medicare severity DRG policy that was introduced in 2021, which was going to add in the non-CC subgroup across the DRGs where there were 3 DRG breakouts, is again being delayed. This has been delayed now for a couple of years, and the concern really is that they just simply don't have enough information to ensure that this policy is implemented. This is going to really change the number of DRGs that are currently out there. A lot will drop off, a lot will be added, and it'll create a lot of volatility. They've put the tables out on the CMS website so that hospitals can do some analysis here to make sure that they're in line with this, and if they can provide any other feedback to help them set this policy correctly. So they are very cautious, knowing that there's a lot of volatility in this particular policy. Another policy that they introduced in the past, but we're seeing actually is being introduced, is this idea of the 9 guiding principles that was introduced a couple of years ago. It's actually being applied this year to determine whether the secondary diagnosis on a claim should actually result in a higher CC/MCC. They introduced these 9 guiding principles to kind of help them evaluate particular things to see if there's additional resource usage that actually should result in a higher reimbursement payment. And we're going to talk about it a little bit later today, but there are the expansion of diagnosis codes for determinants of health, social determinants of health, which we can talk about a little bit later. And just really quickly, the new technology add-on payments, there was some policy change here. There are 5 new technologies that went under the traditional pathway and 12 under the alternative, for a total of $769 million in additional reimbursements. They changed the timing in the policy as to when hospitals can, or when technologies can qualify for this, and how we define newness under this program. And so that's important. They also changed how the percentage increase for NTAP technology on certain gene therapies to really promote those particular things as a potential cost savings down the road. And that's going to take us to our first poll question. Amy?
All right, thank you, Eric. So the first poll out of 4 is, how important is financial modeling of the IPPS payment updates to your organization? And your options are A, extremely important, review changes closely; B, important, routinely model impact of proposed and or final update; C, somewhat important, some modeling is performed; D, not critical; or E, not applicable. And the polling questions are located right on the slides that we're presenting. So if you can't see it, you may need to hit F5 to refresh your console. And then just a reminder, click the button next to the answer you choose, and then make sure to hit submit. And most have responded. We'll give this another 5 seconds or so. All right, here are the results.
Oh, great. That's exactly what I was kind of hoping to see here. I mean, typically there's so many moving parts here that just simply taking the overall percentage and applying it to the hospital is simply not really going to get to the answer for most hospitals. So understanding all those moving parts and modeling around that is, kind of exactly what you would hope the priority would be. So that's great. Okay, well, this turns it over to what I think is probably one of the most significant regulatory changes, and that is the team model. Georgia?
Thanks, Eric. So today we're going to talk about the Transforming Episode Accountability Model, or TEAM. And this is getting a lot of attention right now because it is a mandatory payment model for acute care hospitals. If you're paid under this IPPS rule, which is probably all of you that are on the call today, that's why you're interested in this topic. It is mandatory in the 189 randomly selected CBSAs, or core-based statistical areas. These are essentially micropolitan areas. I will say, if you are looking at that list of CBSAs, just keep in mind that the name of the city or cities, the title of the CBSA, might be a smaller area, and if you actually map it, it's quite larger than you think. For example, the San Francisco one extends pretty far north into the North Bay, pretty far south into the South Bay, well, way into the East Bay. So some of them are bigger than you might expect. So it is a mandatory model if you're in those areas and performing one of the 5 surgeries listed down at the bottom. That's lower extremity joint replacement, surgical hip femur fracture treatment, spinal fusion, coronary artery bypass, graft or cabbage, and major bowel procedures. You can also voluntarily opt into the model if you are a participant in the Bundled Payments for Care Improvement Advanced or Comprehensive Care for Joint Replacement models. If you participate in those until the end dates of those respective models, then you can sort of voluntarily roll into the team model, which is a similar type of program, bundled payment around surgical episodes. And you don't have to be located in one of those CBSAs. So no matter where you are in the country, you can opt in. That opt-in process will happen through submission of a letter of interest in January 2025. So stand by for details on how you can do that if you want to do that. So this is an Innovation Center, Medicare Innovation Center, CMMI model. And like all of those models, what they're all about is, of course, reducing the total cost to Medicare for caring for Medicare fee-for-service patients and improving quality, clinical quality, patient outcomes, patient experience. So it incentivizes you to kind of work on both of those two things at the same time, like any value-based care model does. In this particular model, looking at these surgical episodes, they are requiring you to refer the patient back to primary care. The idea is to reduce fragmentation of care, have more, coordinated transitions, and again, reduce the readmissions back to the hospital, which is going to reduce the overall cost. You do have some time to prepare for this model if you are mandatorily selected for it. So it won't start until January 1, 2026, and it will run for 5 years. Again, the way the payments work in this model is Medicare is going to set a target price each year for each of these different episodes. And they are looking at the anchor stay, which could be an inpatient stay or it could be an outpatient procedure. But it includes the cost of that actual surgical episode plus 30 days following discharge. And it's looking at all Medicare Part A and B costs. There will be some things carved out in the fine print that are not included in that total cost. But for the most part, think about it across all hospital, outpatient, SNF, home health, rehab, hospice, did I say that? DME, it's everything that's in Part A and B is what they're looking at in that 30-day episode post-discharge. So it's not just what happens inside the 4 walls of your hospital, it's thinking about everywhere your patient goes in that 30 days after they have their surgery. It'll also factor in your population. So if you happen to serve a high Medicaid, Medicare dual eligible population, it will kind of increase that target price, knowing that those are maybe more difficult patients to care for or higher cost patients on average. It's also going to look at the area deprivation index or ADI score of where your patients live. Those kinds of adjustments will be made. And then the performance on the quality scores in the model also will affect, essentially at the end of the day, whether you receive more payment in that target price from Medicare, or if you owe Medicare back a payment at the end of the year because you exceeded that target price. So there are 3 different tracks in the program, and the table shows your eligibility for the tracks. So of course, over time, they encourage increased levels of risk and reward. And then for rural and safety net hospitals who are selected into this model or opt in, there's the option to stay in a no downside risk track with lower levels of reward in the first 3 years of the model. The details of that, we don't have all of that yet. I'm sure we'll get, a white paper from CMS that really shows the payment methodologies and calculations and provide a little bit more detail about what they mean by that. Also, if for the sake of MIPS reporting, you would get that advanced APM status as long as you're using certified electronic health record technology and you're participating in those risk-bearing tracks, so track 2 and 3. One thing to think about is if you're already in a Medicare ACO, ACO REACH, or other kind of value-based models through Medicare, that these patients can overlap. So the same patient that is your Medicare ACO patient could also be attributed into this team model. I think it's kind of neat because you could get essentially a double payment or a double rewarded if you do a good job lowering that patient's total cost of care. And you also could be treating patients that are in an ACO. Maybe your hospital's not in an ACO, but there is a local ACO. That ACO's patients could be essentially with you for this team model. So it's giving you an opportunity to collaborate with that ACO. The quality measures in the model are hospital readmissions, patient safety, and that's the PSI 90 measure for the quality folks that might be on the call in the first year. And then that measure is getting phased out and replaced with 3 measures in the second year and beyond. And the patient reported outcomes PRO-PM measure, it's only that patient reported outcomes measure is only relevant to the lower extremity joint replacement surgical bundle, whereas the first 2 are relevant to all 5 of the surgeries. One thing that's sort of a little bit of a wild card, a little different than other models I've ever seen before, is this decarbonization and resilience initiative. So this is a voluntary aspect of the model. So you have to be a team model participant to do this initiative. But under this initiative, you can report to CMS on greenhouse gas emissions from your hospital. And they have that broken out into different subcategories. I'm sure there'll be a lot more information, but thinking about transportation and vehicles and certain medical gases, just different ways that you might be having greenhouse gas emissions. Again, it's voluntary, but you will get public recognition if you choose to do that reporting, and you'll get technical assistance, resources, guidance, et cetera, from CMS if you choose to participate in that. So I would encourage folks to do it. I definitely think I would love to see a lot more, kind of environmental stewardship on the part of hospitals. And then this is, I think, the first step toward a movement that may become more mandatory from federal agencies. So it doesn't hurt to get some practice. Thinking about if you are in this model, how can we get ready for this? How can we prepare? How can we be successful? I know January 1st, 2026 sounds like a really long time from now, but I'm sure time will fly, and before you know it, you'll be getting paid in this new way. So first, I want to just mention that we have a Q&A chat box on the webcast, and only we here at Moss Adams will see your comments. So if you want to throw any questions in there, feel free to. We will follow up with you after the webcast and just email you back an answer. But the very first thing is confirm your participation. I've had quite a few conversations with clients in the last 2 weeks telling them, hey, you're sitting in the CBSA that's in the model, right? And it's not top of mind for everyone. So I would just say, make sure you take a look at that list. And if you're not sure if you're in, feel free to put your city and state in the chat, and we'll follow up with you and let you know how it looks. Second, think about your team, who's going to be involved in this. It should definitely be a mix of your clinical and surgery team, finance, leadership, quality. You may need some folks on the analytics team. And if your organization has a managed care or a value-based care leader, then certainly they'd want to be involved in this. And then whatever external help you might need, certainly you can reach out to us. You might have other consultants and experts that you work with as well. Think about benchmarking. So for those who participate in the Medicare Shared Savings Program, or if you've been in BPCIA or CJR in the past, you probably have seen what they call shadow bundle data, or 90-day episode data around your surgeries. So if you have that information, I would say now is a good time to tap into that and see kind of how you sit relative to other hospitals in the country, national averages, regional averages. Those data sources can be useful. If you don't have access to that, reach out to us. We would love to help you get a sense of, how you're doing on each of those 5 episodes, relative to your peers. And that can be really good directional guidance. It's not exactly one-to-one because those are 90-day episodes. This new model is a 30-day episode. So it's slightly different, but we would still I find it really interesting and useful to look at, and gives you a sense of your volumes as well. Operational planning, very important to start thinking about whether you have a care transition, care coordination, care planning program, and how you're going to make sure that the patients who are receiving these surgeries are routed into that program. Definitely want to have education and collaboration with your surgical specialists, and connecting them with the right primary care and therapists in your system to keep patients out of the hospital again, and keep them in the highest quality post-acute care settings. Also, the quality measures, luckily there's not really an added quality reporting burden in this model. As far as I can tell, it's just things that you probably already are reporting on. But just making sure that you're aware of the importance of those measures, how you're doing, again, benchmarking, how are you doing? Can you improve on those measures? This really ties in nicely if you have a service line optimization strategy to work on pre and post-op planning, to enhance the communication and reduce care variation and reduce length of stay with your patients. So, if you haven't already started on that kind of quality initiative, this might be the perfect motivation and the perfect time and reason to start on that kind of work. And of course, I'm going to make a shameless plug. I hope you'll reach out to us if you do need some help with that. We would love to assist you in getting started with that. Also, very important to keep in mind a data-driven approach. If you have never received this kind of data before, you may, take some time to kind of wrap your arms around the claims and utilization data that you'll get from CMS. CMS is very motivated, it seems to me, to provide a lot of data transparency. Sometimes it's almost too much and folks don't know what to do with it. But you'll be able to see, those patients that we have that are getting these surgeries, where are they? Where is Medicare spending money on them in that 30-day episode? Where are they going? What are their post-acute care providers? And if you can start to understand that now before it even starts, then you can start to, kind of route patients to those high-value partners of yours. Also important to make sure you share the information internally with the folks who can affect it. So whether that's the surgery specialists themselves or a care coordination team, you want to make sure that you have mechanisms to disseminate that information and make it meaningful for people. So that's all the information I have. I do see questions are starting to flow into our Q&A box, so I'll take a look at those, and Amy will move on to our second polling question.
All right, thank you, Georgia. The second of 4 polling questions is, team model is coming, are you prepared? And your options are A, I'm not sure if my CBSA was selected. B, my hospital is not participating. C, my hospital is participating and we are feeling confident. D, my hospital is participating and it will be a big lift. Or E, not applicable. And then also just a reminder that if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. And then again, make sure to click that submit button once you select your answer. That way it can register your response.
I see, I think a pretty repetitive question here is just, where can I find that list of CBSAs? It is just sort of buried in the federal rule. Sorry, let me try to find the page number and I'll see if I can find it real quick. But it's basically just a very long list toward the back of a 2,000-page document. So how about this? We'll update our team model article on the Moss Adams website and include a link to those CBSAs so that people can reference it. But if you're curious about your individual one, just throw your city and state or your organization name in the chat and we'll cross-check it and get back to you. Oh, wow. So, yeah, see, a lot of folks are not that sure if their CBSA was selected. So, yeah, I guess I'm not surprised to see that. There are about 800 CBSAs in the country, and they selected 189. So about a quarter of the country is selected into the model. Okay, we will pass it back to you, Eric.
Great, thank you.
Thanks.
Okay, let's talk about the wage index. Going back to this slide, we talked about the breakout between the labor and the non-labor portion. Now the factor that actually gets applied to that labor portion to come up with our labor-related rate wage index. And there's two significant issues that are changes that are occurring in this current year that we want to jump on here. But let's start by just kind of talking about the current year. The wage index is using the data from FY21. There is still a little bit of public health emergency in there. They recognize that in the comments. We're also incorporating the brand new occupational mix survey that was worked on just recently, and that's for the first time being incorporated here, which is certainly going to have some impact because we saw a lot of variation between the current occupational mix and the previous occupational mix. The FY25 unadjusted national average hourly wage right now is $55.03, which is a 8.7% increase over the prior year. And when we adjust for occupational mix, it is $55.97. But this takes us to the biggest change. We were just talking about core-based fiscal areas. So let's talk about the CBSAs, because for wage index purposes, CMS apply the change to the labor market configurations using the current census data. And they release this information in an OMB bulletin. There's pretty significant changes overall to the layout of the CBSAs. We have some that were urban going to rural, some that were rural going to urban, and some just switching over to CBSAs altogether. They finalized this proposal with no change. So the numbers, there are 53 counties currently urban that are going to become rural, impacting 33 hospitals. Not a lot of hospitals, but it's a pretty big change going from urban to rural and can affect reimbursement, specifically capital dish, which falls off for those rural hospitals. 17 of these counties are Lugar counties, which we'll talk about in a second. There are 54 counties that are currently rural that are now going to become urban, impacting 24 hospitals. And that will change their reimbursement for the exact opposite reasons the others. They're going to have additional reimbursement coming in. So it's definitely quite a change for a few hospitals that are out there, but there are also some urban counties that are changing as well, where a hospital could be in one urban and now they're in a different urban CBSA. So some things to think about here, because if you're in one of these buckets, you might find yourself now having a hard time meeting some of the criteria for your designation for your hospital. So for example, critical access hospitals, which require that they be rural, and so community hospitals or Medicare dependent hospitals are going to find themselves in this situation. Also, if you're in another CBSA right now, they might have a lower wage index And so that could have a factor too, as far as the calculation. It is important to point out, though, that there still is the 5% cap on the decrease to the wage index. So, you won't fall over a cliff as a result of this, but it's important to look to see if your hospital is impacted by these changes, because these could be significant changes. Good point. I'm going to just breeze through that just to point out that that the geographic reclassification process and the redesignation process to actually move your hospital for wage index purposes from one CBSA to another, or from rural to urban, is an opportunity and should be evaluated now, given the changes that have occurred. The slide itself has the criteria for doing something like that. And certainly if it's something you want to discuss, please reach out to us, let us know. And then there's also the ability to redesignate from an urban setting into the rural for a number of payment purposes. And that option is also something that needs to be considered for hospitals that find themselves moving from a rural setting into an urban and need to get back to rural for payment reasons. Lugar County is a rural county that's adjacent to urban areas where the workers are actually from those other areas, those urban areas. And in those situations, the hospitals are deemed urban because that's where the worker base is from. And in those cases, they automatically become urban from a payment perspective. There's no actual changes to the way they calculate the wage index policy this year. It is important to point out if there is errors or aberrant data within the cost report wage index, they will adjust those out and put a proxy in. And in this case, that it did happen for a few hospitals. So it's important to review that information when it's published later, as it could affect particular hospitals where there's, where they really represent a big part of the wage index factor. And then there was also some occupational mix surveys that were not properly completed, or they had some errors in them as well. And so there is a mix match between the number of wage index hospitals being applied versus occupational mix, but it's a pretty high rate from CMS's perspective. So here's the other. This is the second big one, and it's important to bring up. A few years ago, fiscal year 20, CMS releases the low wage index hospital policy, which was essentially a way of moving hospitals that were in the lowest quartile up to a higher, or adjust their wage index up. The concern was that there was a death spiral being created where the Medicare process was hurting these hospitals' ability to actually raise their labor force salaries. And so this policy was created. And in the meantime, they did this by making it budget neutral. So taking dollars away from the hospitals outside of that 25% and boosting those other hospitals up. In doing so, a bunch of hospitals actually appealed this issue or sued CMS, and CMS lost. I mean, part of the factor was there was a lot of people saying, why are you making this budget neutral? This should not be a budget neutral factor. And then there were some that just disagree with the policy altogether. They lost, and just in July, the appeals court took up the issue and essentially agreed with the lower court. As a result, this now has 90 days from July, so we're talking late October, for CMS to decide how they want to move forward. But in this particular situation, they decided to continue on with this policy. Not only that, CMS indicated the data that we got from this policy in the initial 4-year period is problematic because we had the public health emergency. So we need to do it for 3 more years, from 2025 to 2027. And so we're going to have to kind of watch to see what is CMS going to ultimately do with this policy. Okay, so I raced through that. Let's, Amy.
All right, thank you. The third of 4 polling questions is the wage index regulatory changes are significant. How would you rate your understanding of the changes to be implemented in 2025? And your options are A, thorough understanding, B, working my way towards a good understanding, C, I might need more education on this, or D, not sure. And while you're responding, I do want to let you know that you can download a copy of today's slides if you would like those now from the console. And then we're also sending them out tomorrow via email along with a recording of this webcast. All right, here are the results.
Oh, that's good. Okay. I mean, this is significant policy change, so it's important to make sure not only understanding why the wage index has changed from year over year, but in this case, there's so many moving parts that doing that analysis is good. So that's good. For those that do need some more education, please reach out to us. We can certainly walk you through it. Let's now turn over to one of the other big dollar changes. Jonathan.
All right, thanks, Eric. So I'm just going to take a few minutes to go over the DISH UC payment section of the rule. What started in the proposed rule as an increase from the prior year has now turned into actually a decrease in the UC payments year over year. So on this first slide, UC payments are the products of 3 factors. Factor 1 is the difference between the Secretary's estimated Medicare DISH payments, if it was paid under 100% DISH, less what CMS calls the empirically justified amount. It's a 25%. So you see here the starting baseline total is $13.4 billion. They trend that up to ultimately derive a total of $14.01 billion, and that's a small uptick from the proposed rule. So right here, it's just a view of factor 1 from a trending standpoint. In the end, factor 1 is that $14.01 billion less the 3.5 empirically justified. So factor 1 is $10.509 billion. That's actually $495 million more than last year's total. So moving on to factor 2, this is the factor calculating the change in the uninsured rate. And this is where you see the biggest change from the proposed rule, and one where I think, at least from the provider community standpoint, we've seen a lot of questions about where CMS is getting their data and how and why they expect the uninsured rate to be so low in 2025. So first, just to give you the values from the final rules, the estimated uninsured rate is now 7.3 and 7.77%. You can see those dropped by over a percentage point from the proposed rule. And so after running it through the whole formula, factor 2 now equals 54.29%. That's an almost 8 percentage point drop from the proposed. CMS states that the underlying data and methodology to calculate this uninsured rate is consistent with the prior year calculations, and estimates that they're always updated from the proposed to the final. This included recent data from the National Health Expenditure accounts that became available on June 12th of this year. So several comments from the proposed rule asked CMS to ensure that this updated data used those the Medicaid redeterminations that's been happening across the country and patients falling off the Medicaid rolls, make sure they're properly accounted for. In the final rule, CMS actually addressed these comments and states that their estimates accounts for this increase. However, there's mostly offset by the extension of the American Rescue Plan's marketplace enhanced premium tax credits, and that's I think via the Inflation Reduction Act. So actually their assumption is that many individuals who are being disenrolled by Medicaid are expected to already have comprehensive coverage from another source. And so from 23 to 25, enrollment in those direct purchased insurance is projected to increase by a total of, I think, about 8.3 million. So those updated projections ultimately caused the factor 2 to decrease by so much from the proposed rule. And so in the end, the factor 1, factor 2, 54.29, factor 1 multiplied 10.5 million, you get the $5.7 billion that will be distributed to 2,400 hospitals. That's down 4% from the last year. Here's a trend. You can see it's been going steadily down from 21 through 25. And then ultimately how they derived an individual hospital's calculation, that's called the factor 3. It's using the audited data from 19, 20, 21. So still a 3-year weighted average. The only change from the proposed to the final rule was the interim UC payments are calculated using only 2 fiscal years. They took out fiscal year 21 due to COVID. But beginning in next year's calculation, they'll go back to the 3-year weighted average. And again, they reiterate that all future factor 3 calculations will come from a 3-year blend of audited UC data. And I'll just kind of skip some of these slides, but the point I'd like to make is we did some analysis on what the audits of the S10s, line 30 versus post audit S10s, and you can still see that throughout these 3 years that are being used in the calculation, you can still see that there's still significant change from those as filed calculation to ultimately the audited calculation, whether that's from audit adjustments or whether that's from hospitals revising calculations. You can still see a massive drop in those. So we continue to see these audits carrying forward just because of these significant changes. And these next slides are just subsets of that line 30. That line 30 on your S10 drives your UC calculation. So these are just updates from charity and bad debt. And the only other thing I'd like to mention, this wasn't in the rule, but it's related to DISH and UC's payments. It was a recent court decision outside of this final rule. It impacts Section 11 waiver days. If you remember, CMS published a rule last year excluding certain waiver days from states that had a UC pool. And that was beginning with discharges on 10/1/23 and forward. And so there was just a recent decision, I think it was actually on August 15th, a group of Texas hospitals sued HHS seeking to include these days. And the District Court of the Northern District of Texas ordered that CMS's rule excluding these days was an unlawful agency action, and that rule be vacated. So HHS has, I believe 60 days to appeal from this ruling. And so I just raise it to the provider community. So hospitals within those states, and I've listed them on the slide, Texas, Florida being the 2 biggest, but there's several others. They need to keep a close eye on this litigation as it moves through the courts. I think I'll turn it back over to you, Eric.
Okay. A couple things on GME. Number one, CMS had asked for had an RFI to help them define what a new medical training program, how it should be defined. And the responses actually didn't help them change policy so much as actually ask the question a different way. So there is an RFI out there for additional information on how they should actually define a new medical training program, and this is particularly interesting from a rural provider perspective. So I would urge those in that setting to take a look and potentially respond. There is additional slots to release through the Consolidated Appropriations Act of 2023, not to be confused with the previous one that was already releasing a significant amount. This one, at least 100 needs to go to psychiatry or psychiatry subspecialty. The hospital needs to demonstrate that they will be able to use these slots for the first 5-year training years. And they've developed a process here to ensure that it gets into the hospitals that within these particular subgroups: rural hospitals, hospitals in HPSA markets, hospitals currently exceeding the limit in those states with newer expanded medical schools. They're using these different groups to make sure that they spread the slots effectively across these different areas. And in each one of those groups, no hospital can receive an additional slot until all hospitals that qualify are included. There still is the previous program in that case, the Consolidated Appropriations Act of 2021 has phases 3 and 4. They changed the priority of some of the conditions there, so there will be some change there. And then there is one hospital program or one teaching program that has expired in Wisconsin, where those slots will be available for those hospitals who are applicable. That application is due October 30th, 2024. So it's related to quality programs. There's not really much in the change as far as the quality reporting. There are some new measures related to patient safety. Nothing here that's really going to move too much the needle from value-based payment perspective. They made some changes to the patient surveys and really want to weigh those a bit more. That reporting starts now. It's not going to actually affect value-based payments until 2030. There's no change to readmission, no change to the hospital-acquired conditions. From a health equity perspective, as I mentioned earlier, they did add a few more CCs. In this case, it was to hospitals or the more to expand on the homelessness issue, and this is more inadequate housing and diagnosis codes related to that will now actually result in a higher severity case, a CC or an MCC on an encounter, and therefore receive additional reimbursement. And CMS continues to say, look, this is an area we want to expand in. If there's other areas where other social determinants of health that you think impact the resources usage of a case, of an episode, please let us know so we can evaluate it in this program. And this has now been expanded to the long-term care quality program as well. I'm trying to get to the last thing. The long-term care acute hospital, there's a 3% increase. They created a additional reimbursement payment for hospitals that carry buffer stocks for essential medicines. There's 87 medicines that have been identified, but only hospitals that are not in chains and are less than 100 beds will qualify for this. There will be new worksheets on the cost report to identify the cost related to this, and payments will be made through lump sum or through a settlement at year end. The Medicare dependent hospital, low volume hospital, those had been extended through the end of the year. They are set to expire. The low volume hospital add-on is not so much expiring, except the language that expanded this program is expiring. So right now it'll go from 3,000 discharges down to like 200 discharges. It's a big change that'll drop a lot of hospitals out of this program unless Congress acts. And then the ESRD add-on, this was something that hadn't been changed in quite some time, and it's now connected with the ESRD PPS payment to calculate that amount. And that takes us to the final poll question.
All right, so the last polling question: how much do you think your organization will be impacted by the various health equity provisions in the IPPS rule? And your options are significantly, moderately, minimally, or not sure. We're going to try and move through this one pretty quickly. And then once you have met all CPE requirements, your certificate will be available to download now in the CPE progress window. And then a copy will be emailed within 2 weeks as well.
And while we're waiting, we have a number of questions here. And as Georgia indicated, we'll be going through those and getting responses out to you as quickly as you can, or utilizing it to determine if we need to go deeper into any subjects in future webcasts. In this case, a lot of people aren't sure how this is impacting them. It's definitely something I hear all the time, whether they're using these codes correctly and getting the additional reimbursement that it's due. So it's definitely an issue. It's expanding, and hospitals need to pay attention to it. So with that, we've kind of wrapped it up. We've hit, I think, the high points here. There are some other changes worthy of discussion, but I think we've hit the ones that are really going to impact reimbursement for the majority of hospitals across the country. We are open to any additional conversations to help understand these concepts. But I wanted to point out there's a few other resources available here with links. And then we have the Executive Healthcare Conference in Las Vegas in November. They do this annually, and it is a fantastic agenda again. So I highly encourage you to take a look at it. Thank you for your time today. We'll talk again soon.